Hello everyone. Today we're going to be talking about coronary heart disease and the coronary syndromes. The topics that we're going to be covering are atherosclerosis and myocardial ischemia, and then we're going to talk about the acute coronary syndromes. We're going to start with coronary artery disease. There are a number of different terms that you might hear that are related to the coronary artery disease, including coronary heart disease or ischemic heart disease. There is a short video down at the bottom of the slide that will help explain this condition. Mainly what you're talking about is insufficient delivery of oxygenated blood to the myocardial cells, and this can lead to angina, myocardial infarctions, dysrhythmias, heart failures, and death. So this coronary artery disease and then myocardial ischemia and a myocardial infarction is all part of a continuum of pathology, okay, that leads to impaired cardiac function. It's usually caused by atherosclerosis, and that's plaque formation in the arteries. And then you have ischemia that occurs because you have impaired blood supply. And with the occlusion of the coronary arteries, that's when you can get the acute coronary syndromes like your angina and your myocardial infarction. Here's just a table that discusses the modifiable risk factors for coronary artery disease, as well as the risk factors that you really can't modify. So the etiology of coronary artery disease. Again, the known risk factors are like a family history, or if you have dyslipidemia, where you have an abnormal serum lipoproteins. You also, smoking is a risk factor, as well as hypertension, diabetes, and obesity. So what happens is you narrow the lumen in the arteries, and that can lead to cardiac ischemia, right? You can also have a clot that forms because of the narrowed vessels, and you can also have vasospasms, as well as you can have some remodeling changes in the arteries due to endothelial cell dysfunction. Again, here's a good video on the pathogenesis of plaque formation. This schematic just reminds you that the coronary artery disease is on a continuum. You usually start with plaque formation, which can actually happen quite young, and from the plaque formation you can actually have narrowing of the lumen, and if you have an unstable plaque, then the plaque can rupture, and the rupture can occlude the vessel, causing a myocardial infarction. Here's another couple of good videos where you can review the development of atherosclerosis. So it's thought that plaque formation happens because of chronic injury to the endothelium. Also hyperlipidemia and hypertension, smoking, diabetes, and high levels of homocysteine also contribute to an injury in the blood vessel lining, and that injury will lead to endothelial dysfunction, which means that you're going to have irregular processes between vasodilation and vasoconstriction. Okay, again, with the inflammatory process that happens with injury, you can also see an increased permeability at the vessels, as well as the other inflammatory mediators that will respond, and the inflammatory mediators will also cause damage to the vessels. One of the well-characterized processes involved in plaque formation is the oxidation of low-density lipoproteins in the vessel walls. What happens is that the lipoproteins get into the vessel walls, and then macrophages actually engulf them, phagocytize them, and then they become foam cells, and these foam cells lay down a fatty streak, and that's kind of like the earliest lesion of the lipids. And then a lipid core forms over the area, and a fibrous cap forms, and the fibrous cap can protect the lesion and prevent it from rupturing. However, that doesn't happen in all cases. In addition, these fibrous plaques, the caps that form on top of them, they actually protrude into the opening of the vessel, and that can cause damage as well. So these stable plaques, they have a lot of collagen and fibrin in them, again in those, but the vulnerable plaques have a really large lipid core, and they're prone to rupture. And then when the plaques rupture, they'll cause platelet aggregation at the site, which again will occlude the vessel and lead to ischemia. Just a quick reminder on your lipoproteins. They're lipids that are packed for transport in the blood, and it has a protein carrier to it, and then it contains like cholesterol, triglycerides, and the phospholipids. The three most common lipoproteins that we basically evaluate are your low-density lipoproteins, your very low-density lipoproteins, and your high-density lipoproteins. And this schematic is basically showing you, again, that they're just composed of different percentages of the different lipoproteins or the protein core. And the high-density lipoproteins, they're very helpful because they actually transport cholesterol from the peripheral tissue back to the liver, and that can actually help clear some of these plaques. So what you're going to see once you get these plaques formed in your vessels, you're going to have ischemia distal to the occlusion, right? So it just depends on where you're occluding the vessel as to which clinical manifestations you'll see. If it's in the carotid, you may see a patient with a stroke. If it's in the legs, you may see peripheral vascular disease. In the coronary arteries, you're going to have your angina and you're going to have the myocardial infarction. If it happens in the renal arteries, you can get hypertension and end-stage renal disease. Therapies are going to center around risk factor modification and reduce plaque formation. You're hopefully going to help prevent thrombus formation, and or you can actually try interventions that will help stabilize the plaques so that they'll be less prone to rupture, and that includes exercise. So let's talk a little bit about ischemia and the coronary syndromes. Ischemia is when you have insufficient oxygen supply to meet the metabolic demands. And what happens is if myocardial cells become ischemic, they can within like 10 seconds of a coronary occlusion, but they will remain viable for about 20 minutes. What happens is, though, if the cell is deprived of oxygen, it's going to switch from anaerobic metabolism and it's going to switch to anaerobic metabolism, which is good for a little bit. However, lactic acid is the byproduct of anabolic metabolism, so that's not great. And then after several minutes, the heart's going to lose the ability to contract, and you're going to have decreased cardiac output. And then the critical factors in meeting the cellular demands of the myocardial cells is the rate of perfusion for the coronary cells, as well as how hard the heart is working. We know that some of the mechanisms that will impair cardiac oxygenation is thrombus or the plaques, but also coronary vessels can vasospasm. And then there's also an auto-regulation of the microcirculation in the heart, and that can fail. Or you just may have poor perfusion. So the workload of the heart actually depends on, again, the heart rate and the preload, afterload, and how hard it's contracting. Okay? And high afterload is the most detrimental because it increases the cardiac work without producing a higher cardiac output. So if your oxygen supply is impaired, one of the things you might want to do is decrease the oxygen demand by the cardiac workload. Okay, if you can decrease the cardiac workload, hopefully the oxygen supply will be at least more, sufficient. So if you want to decrease the workload of the heart, you would want to focus on conditions that increase the myocardial O2 demand. And so what you're going to want to do is you're going to want to have rest. Strong emotions will increase the oxygen demand, so you're going to want the patient to be calm, and you're going to want them to abstain from heavy meals and sexual activity and stimulants, right? So in an individual who has a healthy heart, increasing the cardiac workload does not cause any of these issues. However, if there's an underlying problem with coronary perfusion, that's when you're going to get an increased risk of these coronary syndromes. So let's take a look at the coronary syndromes. We're talking about unstable angina, myocardial infarction, as well as sudden cardiac death. One of the chronic coronary syndromes is a stable angina. Okay, so you have stable and unstable angina, and then you have myocardial infarction, and then you have sudden death. So let's start with angina. And angina is chest pain, and it's going to be caused by a myocardial ischemia, either because you have a decreased blood flow or you just have reduced oxygen supply compared to demand for the myocardial cells. So angina is classified as stable, unstable, or Prince-Metal's. Okay. The chest pain will actually, people will complain of like a burning or crushing or squeezing sensation of their chest, maybe an elephant sitting on your chest. You can also have referred pain to the jaw, neck, arm, and back. They may be sweating or lightheaded, a little bit of hypotension. You have pulse changes. It could be low or high. Indigestion, and you're going to have some changes on the EKGs. Now with stable angina, basically you have the onset of ischemia that's pretty much predictable with certain activities. What happens is we think that if an artery is occluded with about 75% or more, then what happens is once a person reaches a certain amount of exercise or strain or increased workload on the heart, it's predictable that the patient's going to have ischemia. Okay? This can be asymptomatic unless you increase the demand for oxygen. What happens is with the stable angina, it resolves with rest and nitroglycerin. Nitroglycerin will actually cause coronary and peripheral vasodilation. So once you dilate the vessels and you get more blood back to the heart, the pain goes away. Now in the unstable angina, you've got pain that occurs basically with increasing frequency and severity over time. It's not as predictable as the stable angina, and if you have, the pain will actually continue a little bit even when you decrease your activity or stress levels. It can actually occur when the patient is resting, and again, it's just an ischemic episode that's happening in the coronary vessels. The unstable angina is a high risk indicator for a future myocardial infarction. The treatment is similar to an MI, and the unstable angina is actually very difficult to distinguish from an actual myocardial infarction. So you need treatment and evaluate the serum enzymes to make sure what's going on in the cardiac muscle. In this schematic, it just shows you the pathogenesis of some of these unstable plaques. And so if you have an unstable plaque, that can lead to the angina. What's going on is that one of the plaques will rupture, and once you have a rupture of the plaque, you can get a thrombus formation over the lesion, and that will also vasoconstrict the vessel, and that will again decrease the blood flow. And so that's an unstable angina. And again, it's very difficult to distinguish it from an MI. With Prince-Metal angina, basically what we think is happening is the coronary arteries are having vasospasms. The onset is really unpredictable. It can often happen when the patient is asleep, and so they can have pain during rest. And it may happen at the same time during the day. It needs treatment, so you're going to reduce your risk in therapies in case there's plaque rupture or thrombus and dysrhythmia. So one of the treatments for this is going to be your calcium channel blockers. So that's going to inhibit the vascular smooth muscle contraction and hopefully stop these vasospasms. So again, the unstable angina and the myocardial infarction, they're difficult to distinguish based on the clinical manifestation, so you just treat them the same. The pathology is that you've ruptured an unstable plaque, and then you have the thrombus formation. And then when you have the thrombus formation, it depends whether you have a partial occlusion or you have a complete occlusion and the prolonged vasospasms and everything that goes along with an MI. In this schematic, again, you can see the differentiation between the unstable angina and an MI. What you need to do is, if you take a look at the signs and symptoms of the cardiac ischemia, and you'll start seeing characteristic changes in the EKGs. And one of them is that you'll start seeing an elevation in the ST segment. So you can either have an elevation in the ST segment, and then you check your biomarkers to see if there's been damage to the cardiac cells. And so this would be an ST elevation of myocardial infarction. And then over here on the right, the EKG does not show an ST elevation, but you need to definitely check your biomarkers, okay? And then if your biomarkers are negative, that means that the cardiac cells have not died, and so you have an unstable angina. However, if you do have positive biomarkers, then you've gotten what they call a non-STEMI, which is no elevation of the ST segment, but you still have an MI. It's good to note that elevation of the ST segment on the EKG is evidence of acute ischemia, and the patient is a candidate for reperfusion therapy. Okay, so the definition of a myocardial infarction is that it tends to be more severe and prolonged than angina, and it's not relieved by the nitrates. Patients describe a heavy or crushing feeling to their chest and an unrelenting indigestion, and again it could radiate to the neck, jaw, back, shoulder, or the left arm. Another thing you want to do is check for serum biomarkers. Okay, what happens is that there's enzymes in the muscle fibers that when they are damaged by injury, they will be released into the bloodstream. Okay, and so what you can do is you'll take blood samples and check for the serum biomarkers. There are a number of serum biomarkers. However, the troponins, okay, are the cardiac troponins, particularly I and T, are more specific indicators of an MI. In particular, the cardiac troponin, okay, I, is the most specific indicator that you've got damage to your muscle cells. Okay, other biomarkers that you'll see ordered are creatine kinase, particularly the myocardial branch of the creatine kinase, and you'll also probably see lactate dehydrogenase. There are different types of lactate dehydrogenase. They're called isoenzymes, and LH1 is actually specific to the cardiac muscle. And then you also may see myoglobin. It's not really specific to the cardiac muscle because it's present in cardiac and skeletal. So your most specific is going to be your cardiac troponin I. But you'll also see people order the troponins I and T. So this slide goes over a little bit more of the laboratory confirmation between an MI and an unstable angina. However, again, treatment protocols are about the same. They are the same for both. So hopefully you will reperfuse the area, and then the patient may need some antiplatelet therapy as well. Here are just some alterations in the EKG that are associated with ischemia. You may see a T-wave inversion that the ST elevation is indicative of ongoing injury and ischemia. And if you do see a patient with ST elevation, that patient is a candidate for reperfusion therapy. So if your patient actually does have a myocardial infarction, they're going to be complaining of pain. You will see the elevated serum markers, and you'll probably see some fever and elevated white blood cells. You're also going to see some indications that the patient has an elevation in the inflammatory markers, which is the erythrocyte segmentation rate, the ESR, and the C-reactive protein. Those are indicators that there's an inflammatory process that's ongoing. Your patient may also complain of anxiety, weakness, fatigue, okay? And you may also see dysrhythmias. Now, when the heart is undergoing injury due to an MI, you're going to actually decrease your cardiac output. And unfortunately, the way the body is going to try and fix the problem is that it's going to increase the sympathetic nervous system stimulation to as a compensatory mechanism, right, to increase your cardiac output. However, once the body will initiate the sympathetic nervous system, that's going to actually increase the workload of the heart, which again will increase the O2 demand. All right, so it kind of works against you there. So your treatment is going to be focused on reperfusing the heart, but also decreasing the workload and the oxygen consumption. All right, so you're going to want to control heart rate, give some pain relief, and let the patients rest. Complications of MI are all part of heart failures, arrhythmias, shock, and this slide just kind of briefly goes over the treatments for an MI. You'll probably cover that in your pharmacology class, but I thought I would just put it in here for reference. Thank you.